Okay, Andrew, the floor is yours.
All right, thanks. Really interesting to hear people's stories. And I think first thing to say is well done for speaking openly about it. It's a very common problem that we see. It's nothing to be embarrassed or worried about. And we look after a lot of patients who've got incontinence after prostate cancer treatment. So I have got some slides, but I'm also mindful that slides can get a little bit dull and a bit tedious. So what I thought I'd try and do is just summarize what why incontinence can happen and what the treatment options are. And if you want to see some slides, and I've also got some models to show you, which of the sphincter and the sling. So if you would like me to go through that, I can. But basically, I was going to talk for maybe 10 or 15 minutes,
Yep.
and then I've got to try and get my children to bed, which is more challenging than it seems. Incontinence classically is associated with after prostate cancer treatment, but it's interesting actually within the group. I think there were at least two men who'd had incontinence after bladder outflow surgery. So there's a number of different procedures to treat the enlarged prostate. TURP is the most common, HOLEP, green light laser, aquablation, but these can also be associated with incontinence. So it's quite interesting that it's not just cancer treatment. Broadly speaking, the damage occurs to the urethral sphincter, which is essentially the mechanism which keeps you dry. So if you imagine you're having a pee and the front doorbell goes, it's that muscle which you can control, which gets damaged during these procedures. The second continence mechanism that we have is at the bladder neck. And the bladder neck is something you can't control. But when you have an operation on the prostate, such as a TURP, or you go through prostate cancer treatment, that can also get damaged. So it's because you've got two mechanisms which keep you dry, and damage to those can cause to incontinence. Now, incontinence, broadly speaking, is managed or defined as either something called stress urinary incontinence or urge urinary incontinence. So stress urinary incontinence, it's not related to being anxious or under pressure or having a work deadline. It's the kind of incontinence where you laugh, you cough, you sneeze, and then you leak. So it's the classic situation that we tend to see in men who've had radical prostatectomy, who then are left with stress urinary incontinence. And it's a similar story for those men who've had incontinence after prostate treatment that's not for cancer. The other type is called urge incontinence. And that's interesting because one of the treatments that we see commonly is radiotherapy. And radiotherapy can have quite significant long-term impact on bladder function, sphincter function, and sexual function in the same way. They tend to present in different ways. So prostatectomy, you tend to have the symptoms, and there's often an improvement with things like pelvic floor exercises. Whereas radiotherapy treatments, you tend to find that the side effects can come on with time. So they work and present in different ways. But urgency, the definition of urgency is that involuntary sudden desire to void. So it's not, oh, I think I need a wee. It's I've got to go for a wee, otherwise I'm going to wet myself. And if I don't go for a wee, I will leak. Classically, it's made worse if you've driven a long car journey and you get to the front door, you put your keys in, and suddenly something sets something off, and then you can get that urgency. And the reason it's important is for your surgeons who manage this type of problem, we've got to try and work out what the underlying issue is. So, for instance, if it's a stress incontinence problem, that's managed completely differently from an urge incontinence problem. Okay. So, one of the first things that we'll do when we see you is try and work out what's going on. So, everyone talks about, do I need a sphincter or a sling? But actually, first thing is there anything going on in the history? So, key things I'd want to know. And I just wonder if I can share some slides. If I click on this, Ray, let me just see if I can do this. Hang on a second. Let me just see if this works. It may not. Just Ray, give me a thumbs up if you can see that.
Yes.
Yeah. So some of these slides are being produced by Boston Scientific. They make the sphincter and the sling. I'm not paid by Boston Scientific. I've got no financial interest at all. But some of their slides are better than me trying to do it. So what I wanted to, so there's, and they're also American, so everything's in dollars. And I'm just going to breeze through this, but this gives you an idea of some of the figures and the percentages. So what we often find as surgeons who do this type of treatment is that when they go and see their oncologists or prostatectomists for follow-up, it's about PSA, PSA, and PSA. And there's not a huge amount of questioning or support when it comes to issues about continence and sexual function. And the figures, it's probably at least 10% of men are experiencing stress urinary incontinence after prostatectomy. But you've also got to remember the other things that I mentioned in terms of anyone with neurological problems, people with an enlarged prostate. So this is the long-standing patients who are incontinent after TURP, and then those patients who go on and have radiotherapy. It can be a really difficult condition to manage and to live with. It can affect your general health, how you feel about going out and seeing people. There's a significant mental health component to it. There's a cost to it because not all of the pads and the appliances are available on prescription. It can cause pain, and it really can cause a big impact to men who are going through, particularly when they've gone through their cancer treatment. Treatment options. This diagram just sort of demonstrates what I was talking about. So when you have a radical prostatectomy, this thing here, your prostate, is removed, and then the urethra is stuck up and stitched on to the base of the bladder. When you have a TURP, the prostate is rebored, so is shaved away, but you can still get some damage to the urethral sphincter, although that is pretty rare these days. When I was talking about the history, what I would like to know is what's the main cause of the incontinence? If you've got a patient who's post-prostatectomy, who leaks when they laugh or cough or sneeze, but doesn't get urgency, then that's a fairly classical history. It gets a bit more complicated if the patient's had radical prostatectomy and then their PSA's risen and then they've had radiotherapy and actually they get urgency in addition to stress incontinence, and that's called mixed urinary incontinence. And that gets more tricky because the treatment of each of those two different types is very, very different. So you have to be careful. Other key things I'd want to know about are lifestyle factors. So for one person, what might be very mild incontinence that's not really very bothersome, for another person, if they're still playing squash or golf, might be very symptomatic. I'd want to know whether patients with urgency are drinking lots of tea or coffee or alcohol or energy drinks, because actually you may be able to manage some of the symptoms purely by changing lifestyle, reducing caffeine and things like that. Broadly speaking, when you've exhausted all of the lifestyle factors, you then get on to the more invasive treatments. Now, for urge incontinence, so that's patients who are rushing to the toilet, they get the sensation that they need to pee, and then if they can't pee, they then leak. And those patients who don't have stress incontinence, you're then getting into the realms of medications to try and calm the bladder. So these are some common tablets you may have heard about, things called Betmega, Vesicare, Tolterodine. These are all tablets which calm the bladder down and can work very well for patients with urge incontinence. If they fail on that, you've then got the option of Botox. So Botox, that some people might have relatives or children who use that to keep themselves looking young, works brilliantly in the bladder for an overactive bladder, and it can be very, very helpful. So particularly in those post-radiotherapy patients. I guess what the main point of the meeting today was to try and just give you a bit more information about the treatment options for stress urinary incontinence, which from the summaries you all gave, I think most of you are experiencing. What we tend to look at with that, once you look at lifestyle factors, weight loss, supervised pelvic floor physio sessions can be very helpful. And there are quite a few apps available now, which can remind you when to do your exercises. And when you see the pelvic floor physios, they might even talk about biofeedback, which gives you a way of sort of picturing or measuring the degree of the strength of the pelvic floor. And those things can work really, really well. Ultimately, however, if you've got a patient who's got significant SUI, so stress urinary incontinence, and has failed all of the what we would describe as conservative in a non-political sense, then you get on to the surgical options. And the key thing with these is you have to remember they are operations, and it's not uncommon that we see men who've had prostate surgery. And sometimes at the end of the consultation, they'll say, look, Andrew, I know that there's an option that will help, but I just don't want to go through another operation. I've been through an operation before. I don't want to go through it again. And that's absolutely fine. But the options that you have surgically, there are some others, but the main options that we offer surgically would either be the male sling or the AUS. I've got some pictures about what they all are. And this is the male sling. So the male sling, I think it's important to mention it is a mesh, and you may or may not be aware of something called the Cumberledge Report, which looked at mesh harmed women. It's been a big thing over the last 2 to 3 years. But it is a mesh, and there's not been any reports of any mesh harmed men. And what it does is it sort of supports the urethra. So if you look at this picture, you can see where the prostate's been removed and the urethra's been stitched back to the bladder. It supports the urethra, but you actually then tension it slightly so that it sort of hoiks the urethra up, and it helps with incontinence. The advantages about the male sling are that it is it's a quick procedure. It takes under an hour to do. There's less that can go wrong, so there's no moving parts, and I'll talk about the sphincter as well. It's probably a quicker recovery, and we try and do it without a catheter, try and do it day case. The disadvantages are it can't be removed, so meshes sort of become incorporated into the body, so it's difficult to remove, and it's not as effective for men with severe incontinence compared to the AUS. The AUS has been around for about 40 years, and it's not really changed. They've changed some little things. So I don't know if you can see my model here, but they've changed some of the connectors over the years, and they've changed some of the antibiotic dressing. But on the whole, it's something which has been around a long, long time and has not really changed, which I think is quite interesting. Almost 200,000 patients across the world have used it, and it still is the gold standard for stress urinary incontinence for men, and it's also now being used for stress urinary incontinence in ladies. This is probably an easier thing to see rather than my model over Zoom, but you've got three points really. You've got the cuff, which is what we put through around the urethra. You've got the pump, which sort of becomes an extra testicle, which is in the scrotum. This is all underneath the skin. And then the reservoir, which is where the fluid fills, which sits through a little scar. If any of you have had or have friends who've had a hernia repair, the scar is in that sort of region up in the groin. And what you do is when it's put in, and to be honest now, it takes us probably about an hour and 15 minutes, an hour to do. So it doesn't take long. You have a catheter in afterwards, but it's left not activated when it's first put in. And then we bring you back to clinic, take the catheter out after the catheter's removed day 1, and then we bring you back to clinic in 6 weeks and activate the device. The advantages with the AUS, it's the gold standard. It's really effective for men with significant stress urinary incontinence. You can't see it. It's similar to the sling. It's not visible. Nobody would know you have it. And it's a really effective treatment. It's probably the best operation that I do. Disadvantages of the AUS, I think I've got, here we are. It can stop working. So I think one of the guys on the call said that Susie put it in around 12 years ago. On average, they last between 8 to 10 years. If you're in your late 70s, then that may not be relevant for you needing a replacement because something else might have caused you to pass away. But if you're in your 50s or 60s, you're likely to need a revision. You can also get problems with erosions. And one of the big things we see is when you then go to hospital with another reason, say, for instance, having a knee replacement and you have a catheter, you've got to be really, really careful when you have these put in. So it is something to look after really carefully. So I think that's really all I wanted to say. Key point for me is there are absolutely things that can be done. I had a patient a few weeks ago who had been suffering using 4 pads a day for the last 20 years. And he said, I did not know there was a treatment option for me. And when I took him through his options, it was like sort of, watching The Matrix for the first time. His world was blown. And the point is that if you are struggling, do come along and see someone who looks after patients like you. There are definitely things that we can do. We might want to do some investigations, such as some questionnaires, some frequency volume charts. We might want to look into your bladder, something called a cystoscopy. We might want to do something called urodynamics, which is a pressure flow study, if you like. And all of these things can sound daunting, but they're all okay. And then we'll be able to appropriately counsel you on what may or may not be the best treatment for you. And there are always things that we can do. So I was going to stop there. And if you would like to, how do I stop sharing my screen? There we are. So I guess probably through Ray or Peter, if you want to ask questions, then I'm very happy to answer them.
Well, Andrew, I'm not sure how much longer you've got with us. Bearing in mind your children are there and need some attention at some point. Thank you very much. That was absolutely fantastic. That is very enlightening. Shall we open it up to the floor? And who has a question? Any questions from anybody?
Well, I'm
Yes.
very willing. I'm very willing to ask a question. I mean, basically, as I say, I've been under QA for quite a while now, since August 23. And basically, as I say, the discussion with the consultant last time was I should consider myself lucky, and he seemed to think 1 pad a day is good, and therefore alternatives are not something he would even consider. He did offer me to be transferred over to Southampton to see a specialist there, but he said, in his view, it wasn't appropriate. So that's where I've been left, really, to get on with it.
Yeah, I think that's a tricky one, Arthur. I mean, 1 pad a day would be regarded as fairly mild stress urinary incontinence. Sometimes we ask patients to weigh their pads, so we actually get a volume of what they're producing. I mean, the definition of continence is quite interesting. Some studies, would use the term 1 pad a day or less is continent. Some studies will say, actually, you've got to be completely dry. And there was a big trial comparing the sphincter and the sling, where they used the very rigorous definition. And actually, the incontinence rates, even after sphincter or sling, was still, if you use that definition, pretty high. But I think the key thing is, Arthur, that the patient on the whole is normally right. So it may be that actually at 1 pad a day, you wouldn't necessarily advise somebody to go on and have a major operation such as a sphincter or a sling. But it's still, you are the patient, and you are entitled to what is important for someone. It's really, really subjective. So, if you do want to come along and have a chat, you are entitled to ask for that opinion. It may be that if you came to see me, we'd have a chat and we agreed on the same thing. But the difference is, I think it's nice to get patients seen by urologists who have an interest in this, rather than, because no surgeons like admitting or having patients who've suffered, because it's awful. It happens to all of us. But there's nothing wrong with referring on and asking for an opinion. But yeah, to put it into context, some men I see will be using 5 or 6 heavy pads a day. So it really, that's sort of part of it, I think.
I think mine, Andrew, is my lifestyle. If I'm basically active, then it's bad. And because basically my lifestyle is retired, walk the dog, relax, I'm not doing an active day. And when I do, for example, if I'm out in the garden all day, then I'll be soaking wet and I'll have to change some pads. So it's lifestyle.
Really important. And the whole point about cancer survivorship is that we're encouraging you to get back on your feet. So with that, it's difficult. This isn't a consultation, but with that history, if you're completely incontinent and soaking wet when you've been active, then absolutely you should have a discussion about these things and then be counselled about them. So there's a good guy down in Southampton called Roland Rees, who's very helpful. but also Portsmouth. You could happily filter in and get a referral over to see Susie or Angela at Chichester. Susie also still does clinics in Portsmouth. And I'm at Frimley Park, so I'm not a million miles away. So you can happily ask them to say, can you refer me up to see me? That's fine.
Yeah. Whilst you've done that, Angela, welcome to the
my buddy.
Please feel free to interject or add comment if you feel it necessary.
Yeah, hello. Sorry I was late. I was also doing a school run, swimming for me. Yeah, it's interesting listening to that. I mean, the other thing that I'm not sure if Andrew mentioned was we have used bulking agents in some men with less severe incontinence, but I would say that's more experimental rather than the gold standard of an AUS. And if you are drenching your pads when you're active, then it sounds like, you know, taking on another procedure may be worthwhile for you. But as Andrew said, you know, most men have gone through surgery and prostate cancer treatment, and then taking something else on, it has to be discussed and, you know, the right thing for you.
Brilliant. Dave, Cliff, I know that you were waiting back there in the wings there.
Thanks very much, Ray. Yes, the question was that I haven't had any treatment for prostate cancer. I'm on active surveillance, but I do suffer quite badly with, I'm not sure if it's stress or the other type, but for instance, if I'm out walking the dog, I need to make sure I select woodlands for the walk. So that, you know, it seems as soon as I get up, you know, and start moving around. If I've been sitting down watching the telly for hours, I'll be fine. As soon as I get up, you know, I need to get to the loo pretty damn quick.
Yeah.
And that's not as a result, as I say, of any treatment.
Yeah, thanks, Dave. So that's a really tricky one, because the prostate, it sounds like if you're on active surveillance, you'll have low-grade prostate cancer, something called Gleason 6 disease, possibly low-volume Gleason pattern 4. And you might also have an enlarged prostate, because don't forget, the prostate, to be honest, it's useful when you're young and trying to have children, but after that, it just causes problems, really. And what you might find is if you've got an enlarged prostate, but you're not going to require radical treatment for your prostate cancer, then you might want to have a discussion with your urologist about some of the benign treatments available, which start off with tablets, lifestyle changes, physio, etc., and then go up to some of the procedures that I've talked earlier. The other thing to bear in mind is that if you do have significant what we call LUTs, urinary symptoms, as well as potentially that is an indication to offer you radical treatment. So it's just worth bearing in mind that it can be a little bit complicated. And I think one of the biggest challenges is trying to work out what's going on, because it's not straightforward. It's not like the models that I've described. You know, often men have mixed symptoms and particular symptoms that cause them concern. So it's definitely worth having a chat with your urologist or your specialist nurse who's managing your active surveillance and just saying, look, could I have some sort of assessment about my lower urinary tract symptoms to try and then see if there's anything that could be done to improve them.
I could add to that as well, actually. So, and you highlighted quite well that a lot of men do have these urgent, we call them storage symptoms. So like that urgency and frequency, and when you need to go, you don't get there in time and perhaps leak at that point. And that's what can make it really difficult. So obviously, if you haven't had surgery, but even if you have had surgery, the assumption is that it's stress incontinence because you suddenly don't have a sphincter there anymore, or you don't have a prostate there anymore. But that's why things like urodynamics are really important. That test that Andrew mentioned earlier, again, not the most pleasant test, but we're looking at the flow and the pressures in the bladder, because it may be that actually your bladder is contracting when it shouldn't be, and it's got nothing to do with the fact that you now don't have a prostate. And perhaps an AUS isn't the best choice for you. And that's when, again, tablets or even Botox into the bladder or nerve stimulation can be useful for these overactive bladders. So it can actually be nothing to do with your prostate. It could actually be your bladder that's misbehaving at this point. So it's just really worth urologists and yourselves having an open mind about this and sort of seeing what's going on. And just because you've had treatment for one thing doesn't mean actually that's why you're getting the symptoms. And that's why it can be really complex, basically.
I have been on tamsulosin previously for about 18 months. Wasn't really helping, and I've been put on finasteride for about the last year. That does seem to have helped to some extent.
Oh,
It may be worth you having a flow rate if you haven't done that, to make sure you're emptying your bladder, because obviously if you're not emptying your bladder, it might be something else. Or if you've got an overactive bladder, and then looking at what you're drinking in terms of caffeine and fizzy drinks, alcohol, seeing physios. There's quite a lot we can do without surgery as well.
Thank you.
Can I ask a question?
Can I ask? Oh, sorry. Go on, Mike.
I've been offered the AUV or AUS, which I presume is going to be quite radical as far as surgery goes. All my problems start from basically when I had the TERP. It was a cliff edge. I went in okay, came out basically incontinent. It's not stress or the other one, because as soon as I drink, it comes through. Is there any likelihood that this will resolve itself? I've had the urodynamics. I've also had the cystology, the flexible cystology in there. And the one thing that worried me was when he turned around and looked back at the sphincter, I believe, there was lots of wavy stuff, or as if they'd cut it but hadn't taken it off completely. Is that something that's likely to correct itself before I have to consider having the AUS, sorry?
You'll probably find both me and Angela are hoping that the other one tries to answer that first.
Sorry.
It's really difficult because, as Angela said, there's this phrase, the bladder's an unreliable witness, and it's trying to work out what the cause of your symptoms were, and also whether the cause of your symptoms that led you to having the surgery was the right thing to do in the first place, if that makes sense.
Yes, obviously, I don't think it was, but yeah, it was offered as a possible solution to the fact that I get up every hour and a half and do a small amount. Obviously, in the light of that, it was the wrong thing to do, to have a TERP.
Yeah, but it's difficult looking back on it that way, and it is a challenge. And I think a lot of urologists find managing LUTs difficult and shy away from it because it is difficult and it's not an easy thing. I'll pick up on the fact you said it's pretty radical surgery putting in AUS now. I mean, yep. I think me and Angela are now down to about an hour. We do them, and it is fiddly, but I think we've got it pretty slick now. Okay. And for the right patient, it's amazing. The post TURP, we don't do loads, do we, who are sort of post bladder outflow surgery. And you just wonder with your history whether there might be more going on than this just being sphincter weakness. So you would require sort of, if you were referred over to see one of us, you would probably then have a thorough workup in terms of history, pad weights, frequency volume charts, cystoscopies, maybe repeat urodynamics, and trying some of the tablets that I talked about earlier first, which may or may not help.
I've tried all the tablets and none of them work. I've stopped taking them now. So I've been through the whole gamut of them.
Sure. You know what your urodynamics showed?
The last one, I've not had the report back from it. Yeah. But I think at the moment, my problem is, how do I get out of this situation? Because obviously the TERPers basically make it far, far worse. I put up with getting up every hour and a half if I could actually go out without having to pee myself. I mean, these guys are all saying about pads. Like if I'm drinking properly, which is what I want to do or should do, I can get through 8 or 9 a day.
Great.
Did Andrew talk about a dribble stop?
It's not a dribble stop. I just go. At the moment, I've got the external catheter.
You've got the clamp. Oh, right.
And I can fill that up 2 or 3 times a day if I'm drinking properly, because as soon as I drink, it comes straight through. I've got no choice. It just comes through. It's almost as if my sphincter valve is just open all the time.
Yeah.
Which is hence the question, if they've shaved me and left all these sort of floaty things that are there, will they come off, and will it all eventually sort itself out? Nobody seems to want to answer that question.
How many days or weeks are you or months are you post TURP?
About 3.5 months.
Still pretty early days. I tend to tell patients to judge it by sort of 3 to 6 months down the line rather than the first 3 to 6 weeks.
When you actually cut the prostate and clean it up so that it's there, do you actually normally leave stragglers floating about all over the place? I mean, how close is the prostate to the sphincter valve?
I mean, it's difficult, Mike, because without getting into sort of a consultation territory,
yes,
which
I know.
is
I'm just.
But you don't. What you may be seeing is when you had a cystoscopy, if it was early after your TURP, the cavity takes some time to heal,
right.
And when it goes through that healing process, you can get it can sometimes look a bit sloughy, and you can have little bits of healing tissue which can drop off. You don't leave anything in the bladder or the prostate afterwards. It's meant to leave empty. Yeah. And going back to that diagram I showed you, the sphincter is very close. So I don't know if you can see here. Actually, that's not a good example, but the sphincter is close. But that's our job as urologists to leave it behind. But you can get a situation where you get edema or bruising to the sphincter, which certainly contributes to early stress incontinence after bladder outflow surgery without there being any actual physical damage to it, if that makes sense.
Okay.
But it's a tricky one.
Yeah, you've made me feel better about the AUV, so thank you very much for that.
Yeah. Guys, I'm going to have to say my farewells because I'm a bit worried what my children are up to.
Yeah.
But really lovely to meet you all virtually. And any problems, come and see me and Angela.
Thank you very much.
Okay. Bye, Angela.
Bye.
Peter, could I ask you just to run through your experience with this, because that may also help some of the other patients on the call?
Yes, I'm happy to. Can you all see and hear me? I hope you can.
Yes.
My event started nearly 20 years ago in the Swiss Alps, where I was cycling down a very steep mountainside. When I got to the bottom, I needed to pee, and I peed blood. I very quickly arrived in hospital back in England, and during a whole load of tests, they decided I had prostate cancer, and they basically told, because of my age and my health, just get on and suck it up. They weren't prepared to do anything, so I went online, as you do, even those days ago, found a surgeon who did something called robotic prostatectomy, but it was a very long time ago. And the surgeon went through all the problems. Probably in those days, it was about 50% of people would become erectile dysfunction and incontinent. But I decided I would go ahead with it after watching the Da Vinci robot in action, and I shouldn't have done that. Don't do it, because they say, it's all done in America, and they say within 3 weeks of robotic surgery, you'll be running the London Marathon. Well, I can tell you, I was certainly not running the London Marathon after 3 weeks. In fact, in those days, I became quite severely incontinent, and I was for 9 years, until I met one of these wonderful urologists speaking at one of these meetings, in fact. And he said, no man should suffer incontinence, only in exceptional circumstances. And I held on to that, and I contacted him, and he very kindly took me through exactly what Andrew and Angela have been talking about, the 2 options. We went through everything else as well, as Andrew had said. I did all the tests, or they did all the tests, to find out how much volume I was passing. And it was quite considerable. I was a bit on the high side for a sling, but having discussed it with him and talking to other people online, I thought, I like this. There's no moving parts. Once you've got it, if it works, it should be very good. And so I had the sling about 6 years ago. The immediate effects for the first week were quite worrying because I felt at the start I couldn't pee at all, and at the end I was, quite uncomfortable. But that was just a week. Within about a month, I was completely dry, and for the last 8 years, I've been completely dry. I've never used a pad. I had a huge stock of tenor pads. I took them to a centre, to a private hospital, and they were very grateful to receive this enormous box of unused tenor pads. So for me, it's been a very great success. I have to add the caveat that, all these things are personal to not only the personal anatomy of the patient, but obviously the skill of the urologist, and they are very, very skillful. But the sling has, for me, been a great success, and I know others here that are listening in have had that. I did look at the AUS, but as Andrew has said, and other people have said, it's just a little bit more complicated. It's a bit more mechanical, and if you want to pee in a public urinal, you have to get your hand down your testicles and start pumping, and I think you might get locked up if you're not a bit careful. But I thought, well, I don't know about anybody else. I also had the blue pills. I had an experience with the blue pills, and they didn't work. Erections didn't work for me at all. But I have to say, my next door neighbor came in one day and he said, "Are you taking those pills?" And I said, "Yes." He said, "Well, every time you take a pill, my garage door goes up." And I was obviously affecting his garage door, whereas I wasn't getting the same effect down below. But any questions, I'd be very happy to answer. But I know others are here, and time is a bit tight, I think, Ray, isn't it?
We're getting there, but thank you very much, Peter. I rather enjoyed the comment one at the end there. I shall picture that for the rest of the evening. David, are you there? David, you need to unmute yourself.
Sorry, I thought I was better at that. Yes, one for Angela, if I might. I found this evening quite reassuring because I was thinking that I was getting on the wet side of perfect. I've got an AUS that Susie put in back in 2013, in January 2013. So it's a happy birthday. I'm still using mainly one pad and occasionally two. But the question I was asking is, I haven't done the pelvic floor exercises since I had the AUS in because the AUS was working happily. If I am beginning to get a hint that it's not actually being as good as it used to be, if I go back and try and do the pelvic floor exercises again, would that help?
I think what I'd say there is that it's not going to harm it. So I think you certainly should try. I mean, it depends, at the beginning, does physio help at all at that stage? Do you see what I mean? Because things probably aren't any better than they were then in terms of your tissues 12 years on. But certainly it may help, and I don't think it's going to, it's not going to be detrimental. So it certainly can. And we can replace AUSs if they start to fail. And as I know we've spoken about, they do have, we say about 8 years. So the fact you've got 12 years out of it is, that's great. But you'd also want to, if you're leaking a little bit now, you may want to wait, if you see what I mean, if it gets worse, because as we've been saying, it's a big undertaking. And as soon as you go back into them, and I don't know if you had a radiotherapy as well, but quite often men, quite often now, men have been having radical prostatectomies and salvage radiotherapy or the other way around. And the tissues are never as good as they were before. And you're more likely to erode. So when we go back in, obviously we're worried about infection, and that erosion is our main concern, to be honest, and having to do again. But certainly a second time, if you didn't have the radiotherapy, we could certainly consider. But I know that wasn't quite what you asked. Yes, I'm a strong believer in conservative approaches to anything, and sort of starting again, and holistic approaches to all disease, to be honest, because we're one body, aren't we? And you can't just focus on one thing. Very much step back and think what you're drinking, what you're eating, what you're getting into your bladder retraining, anything you can. And yes, it's worth seeing a physio. It may not, it may not be enough. You've been through surgery already for a reason, so we have to be honest here, but it's definitely worth trying. Good.
I will. And certainly, as I said, hearing what Andrew was saying was relieving me, if I can use that phrase. It actually reassured me that I'm not getting as bad as I thought I might be. Put it that way.
I mean, I've always said that people that undergo any surgery, if you're leaking using 5-6 pads a day, every time you stand up, you drench, you're going to be much happier after an AS than somebody who's, using one pad and leaking a little bit. Everything in medicine is, a toss up between the side effects of something. And certainly if something's much worse, then you're going to notice a much better improvement if that does improve, even if it's not as significant.
Well, certainly having had the AUS back in 2013 when I first got it, well, it was first switched on, the relief was excellent, to be able to walk about without having to worry about where the nearest loo was and all the rest of it. Excellent.
Yeah, I think this is why we do it. And I think as a group of patients, we feel like we're really really doing something and improving quality of life. So it's wonderful for us to see as well.
Yeah, worked for me.
Good.
Quick question for you, Angela, if I may. Andrew spoke about pelvic floor exercises, and you've just mentioned it again. Are there any particular apps or instructions for pelvic floor exercises for men with these types of symptoms that's readily available?
I mean, I usually talk about the Squeezy app. I'm not sure if that's specifically for men, though. To be honest, so I'd look at that and on the NHS websites, but I couldn't tell you one that we would specifically would suggest. I'm afraid one to look into, but yeah, I'd look at the Squeezy app and the NHS apps.
I was told just stand there and do it for 100 times.
Gentlemen, any further questions?
Yeah, just a quickie. I had this catheter in for about 4 months. It's because I had that catheter in, and therefore I was involuntarily peeing. Now that I'm having to use pants, is the problem with my peeing caused because for such a long time while I had the catheter, my muscles weren't operating? Has that got some bearing on the leaking?
So I probably need a bit of background. Did you have the catheter put in because you were in retention and you couldn't pee?
That's absolutely right. Yeah. And then they waited for 4 months, during which time I had the catheter. And I was relieved to find, obviously, that they also removed a stone in my bladder and did a partial TURPs, getting rid of a regrowth from a previous TURPs. But I'm just wondering, because I've had that catheter in for 3 or 4 months, is that contributory to this situation I'm now in?
So what can happen? So when you're in retention in the first place, your bladder can become overstretched. So imagine you've got like a bladder that's been like a balloon, that's been blown up and then it's deflated back down.
Right.
Just like a balloon. So some men are walking around with 2-3 liters. I've seen a man with 5 liters in their bladder and they didn't even know that they had any urine in their bladder. They don't have any feeling. So it's worse in a way if you've got a lot of urine in your bladder and you're not getting that sensation to void, because that means that the nerves are being desensitized.
Okay.
Probably your bladder has gradually been desensitized. We've catheter in to allow it to drain. Yeah. And at this point that you've now got this deflated sort of balloon
the other way
and is now trying to contract. And it's probably lost its ability to contract normally. And I always say, I can give you the best channel in the world with the TURP. You can have a huge channel with plumbers. We've deferred it out. But if your bladder doesn't contract to empty, then you're still not going to empty. Okay. So I'm not sure and yes, there's a theory that if you've got a catheter in, then obviously your bladder, if you didn't have a flip flow on and it was just draining out.
It was.
Then your bladder isn't being used, as it were, at that stage. And that's why I quite like teaching men to self-catheterize, because it's sort of giving you that power back and then looking for the sensation. And then if you can't pee, then passing the catheter, even when you're waiting for a TURP.
Yeah.
Because that's allowing your bladder to retrain itself in a way. And the bladder can be retrained. So now you've had a TURP and you're still peeing, but you're leaking as well.
At the moment, it's really not too bad, I suppose, because I'm only using 2 sanitary pants a day, and I'm continuing, as the nurse said to me, with pelvic floor exercises. But listening to Andrew, I got the impression that sometimes, instead of being 6 weeks to get over something, it can be 6 months.
Oh, totally. I always say the first 6 weeks after a TURP is you don't like us much at all. You've got a cut, an open cut, basically, in your prostate that you're passing urine over. And you can see how that's going to be really irritating for everyone. So that will take a long time to settle down. So at least 6 weeks before you're having to, get up at night and running to the loo. So 3 months, by 6 months, you'd want things to have settled down, but this is still quite early days.
Okay. And also I'd had radiotherapy 3 or 4 years ago. So again, as Andrew said, there probably might be some tissue damage, which takes years to work out.
Well, exactly. And you get radiation cystitis. So even though if the radiotherapy was to somewhere else, you can still get irritation of the bladder, and that in itself can cause overactivity. And this is what we're saying with all the bladder is an unreliable witness. We don't always, we can guess the most likely thing that's going on, but often it's with low urinary tract symptoms. It's trying different things and trying to work out what works with you. And this is what I'm saying, if you can try it as conservatively as possible and then you work forward, because I think previously men had problems peeing, they got a TURP, and that's, that might not be the right thing at all. And this is why urodynamics can be really helpful, and that's why Botox into the bladder now can be life-changing for some men as well if you've got an overactive bladder. So it's what is it that we're looking at? And actually,
is that fairly common, Botox being put into the bladder?
It is for what's called detrusor overactivity. So if you've got an overactive bladder, we've proven that the muscles are contracting when they shouldn't. If you've gone through conservative, you've seen your physiotherapist. And I will say at this stage, actually, you asked about apps. I still believe that the best outcome from physiotherapy will be if you are supervised pelvic floors. So then you're with a physio. So although the apps are good, I personally think having somebody doing it with you, making sure you're doing the right things, because you're doing it, as you say, all for 10 times a day. But if you're doing the wrong thing, it doesn't help. So I do think
I found it difficult initially not to squeeze my bum.
Exactly. Yeah.
But I think I've learned now pretty well that I can do it without squeezing my bum.
Good. Well done.
But thanks ever so much.
Yeah.
I appreciate your help.
No, it's fine. What I was saying is that so medication can help for an overactive bladder. But if it's refractory to medication and conservative measures, then people have a choice of Botox or a thing called sacral nerve stimulation now, which is actually something that I've just done our first cases in Sussex 2 weeks ago. So it took me 7 years to be able to offer it at St Richard's, and I've finally got funding from NHS England, so our patients don't have to go up to UCLH anymore. So we can do that now. But these are specific, these are specific conditions and, overactive bladder rather than stress incontinence.
I've really enjoyed this meeting. I'm just so glad. And I'm a little bit disappointed that there aren't more from my East Sussex group. But as it's being recorded, I'm sure there's a lot of benefit for others who have not been able to attend. It's been really good. Thank you.
Well, you're very most welcome, all of you. I'd like to thank Andrew Chetwood for his time this evening, and to Angela to come on to the call and give her expert opinion, to Peter for telling us a little bit about his experience, and to all of you, the patients out there as well, like me, who suffer from prostate cancer. Thank you very much for attending. It's been quite an enjoyable meeting.
Yes.
Thank you very much for doing so.
Okay.
On that, I'd like to bid you all a very good evening.
Yes, thank you so much.
Thank you.
Thank you.
Thank you for arranging it.
Bye-bye.
Yeah,
Bye all. Take care.
Bye-bye.